to, to understand that how to, so far in our both the sessions, we tried to understand how to identify a cardiac patient. And also in last session, I think most of my lecture has been clinically oriented because I myself am a practitioner. And I like to study and understand from a clinical perspective. That's how I have been. So, and all my lectures have been focused on that. So today's lecture, basically, I'm trying to show you my learning of whatever these cases are. Trust me, each one of them, excuse me for this, each one of them have been an absolutely challenging one, because none of these cases which I'm going to show you are taught in the textbooks. Okay, so it has to come out of your experience through the spur of the moment, and most importantly, through study, right? And trying to analyze, trying to understand your differential diagnosis. Okay, so when I say mimics, cardiac mimics, most of the entire lecture is only about cases. We are only going to see 8 to 10 cases. It's going to be a short lecture, but at the end of whatever you have, whatever the doubts you have, or whatever you want to understand or discuss, though I'm not discussing the treatment part in detail, because my focus is mostly on helping you understand the diagnostics, to come to a tentative diagnosis, how to delineate from a tentative diagnosis, because treatment part I'm going to touch but I'm going to touch a little, so we can have the further discussion in this. So I'm trying to share my lecture now, and just okay. Can you all see that? Doctor, I would like for you to help me understand if you're able to visualize the lecture.
Yes, ma'am. Yes.
Okay, thank you so much. Yeah. So I will not be having a lot of audio things, but there are a few of them. So just in case, if you're not able to see anything, just let me know. Okay, so there we go. Now, when I say a mimic, so this, we all understand what organ we are studying, right? So it's heart. So I'm so sorry for this. So for people who have not attended the previous lectures, just want to give you a briefing about the structure of the heart. So we all understand heart has 4 chambers, 2 chambers in the top and 2 in the bottom. So the top chambers are called as atria, the bottom ones are called as the ventricles. We all understand this thing, right? So the basic structure of the heart. And when it comes to the contraction, the pumping capacity, the contraction, only the bottom chambers of the heart are responsible for all the generation of the blood pressure. The top atria do contract, but they do not contribute in generating your blood pressure. Okay, so we understand the left and the right side of the heart are completely separated by intraatrial septum and the interventricular septum. They should be completely separate. Left side of the heart has your oxygen-rich blood, and the right side has the oxygen-poor blood. Okay, so we all understand this thing, right? Now, most important part here is that whether it is the top or whether it is the right or the left side of the heart, the top and the bottom chambers are separated by very classic valves, V-A-L-V-E-S, valves. So these valves, the structure of the valve, it plays such a significant role in trying to maintain your blood pressure, trying to maintain the cardiac output, trying to maintain the functionality of rest of the organs. Okay, please understand. I always say this is my jargon. Heart does not work by itself, and heart does not work for itself. Okay, you must understand this thing. Now, coming to the clinical cases, what exactly is when I say a cardiac mimic, what is a mimic? Mimic is nothing but it is something like a lookalike, okay? So when I say a cardiac mimic, what I mean is all those complications which may or may not be, which are visible but may or may not be generated or directly involving the heart, okay? So the patient that comes to your clinic will show the signs as if it's a heart patient, but it may not be a true heart patient, okay? So I am basically a referral cardiologist. So people come in Hyderabad and from all around the country, mostly they refer the cases to me. So 90% of the times they are dyspneic patients. You will see those cases coming across. but mostly they're dyspneic patients. So I want you guys to keep your eyes and ears open to see and try to understand what are the other things, what are the other parameters you should also be looking at to, to understand whether the patient that you're seeing right now is a heart patient or not a heart patient. Okay. Now let's start. We will study everything only through the clinical cases. Okay. Now coming to the first case, we'll go from a simple to a slightly complicated case. So Shiro comes to me like this. He's a nice. Okay, he is a nice, good 12-year-old Dachshund and male. And so he comes to me with, so the primary referent has said that he has slightly distended abdomen and he has a slowly progressing signs of breathlessness. The patient prefers standing most of the times with the just wide open. Okay. Now, he was referred to me by the primary vet. Why? Because just one day before in the night, just one night before, he ended up having episodes of syncope, which was actually back-to-back 2 episodes of syncope and cyanosis of the tongue. So that's the reason it was referred to me. Okay, so it looked like that. When you look at the patient, the first thing what you see is the body score condition. How is the body score? Okay, fine. It's kind of an okay. I do see ribs, but it's not very bony. And what can you expect from a 12-year-old? Next important is look at the front limbs. They're still wide open, the wide stance appearance, trying to open the chest so that the breathing becomes more easier. Another important thing is the breathing pattern. When you look at the breathing pattern, I do see there's a slight abdominal, slight distress in the breathing. It's not very dyspneic, and the mucous membranes were kind of slightly cyanotic, not very cyanotic. He was fine, he was active, he was alert. And it was a slightly distended abdomen, but not very huge. Okay. And this was the observation. Now, what are the images that I'm showing to you right now? It's about, so the most important part, what happens is when a patient comes to us, we, apart from looking at the physical examination and, doing the physical evaluation, taking out the analysis, the detailed history and all, then we start getting into the diagnostics where I do a chest x-rays, ECGs, then we go for the ultrasound, okay? Now, after looking into this patient, his chest x-ray, his ECG looked absolutely normal. This is what, I don't have the data in here, so I have not put it in here, but anyways. So when I went and looked in the abdomen, because it looked distended, let me see how the abdomen looked like. I don't know why the video is not playing, but what you can see here is, this is the liver, and I do see a nodule in the liver, okay? And it did show mild ascites, but the ascites was not very intense. It was not a hugely pot-bellied appearance. Now the I don't know why these videos are not playing, but the echocardiography in here, I am so surprised. Can I just share the presentation again, doctor? Probably I have to optimize the.
Yeah, sure, ma'am. Sure, ma'am. Sure, ma'am.
I have to probably optimize the optimization thing with the videos. So give me a minute, please.
Sure, ma'am. Sure, ma'am. Meanwhile, everybody can look at the link and please register yourself for the certificate. The link is provided in the chat box. Humble request to all the doctors. Meanwhile, by the time I'm present, please log in to the link so that we can provide you the certificates.
Well, it is playing at my this thing, but I don't know why it is not playing over there. It's very surprising. Yes, second please. I'll try to play it from my drive. Okay, I'll try to share again and see. Let's see if it plays now. I'm sorry. Okay, don't worry about this. So what basically you're seeing here is, can you see my cursor? Okay, at my cursor, this is the nodule. There is a small tumor in the liver. When we did this echocardiography, what you see here is, imagine the heart upside down. So these two are the atria. This is the left atrium. This is the right atrium. This is the left ventricle. This is the right ventricle. So the heart is upside down. Now, in that, inside the right atrium, there was a very significant growth. There was a huge mass inside the right atrium. Okay, now this is the reason why you were trying, because there was a mass, so there is an increase in the size of the left atrium. When the size of the left atrium increases, the tricuspid valves, those tricuspid valves are not opposing to each other just because there's an enlargement in the right atrium. So that's the reason you see all this different colors here. What is a color? Color is nothing but the turbulence. It is called as a regurgitation. Okay. So when this is an insufficiency on the right heart side. So when there is a right heart insufficiency, you end up having ascites because of the increase in the systemic pressures. Okay, increase in the systemic pressures, or you can also call as an increase in the portal hypertension. Now, this image also is a different view, trying to just show you that, this is the growth which is attached to the wall of the right atrium. It was actually a wonderful case. Unfortunately, what happened is, this is also just another view. Unfortunately, what happened is that day, the pet parents were not really ready for further diagnostics, because once the patient comes in, I tried to explain what are the pros and cons and all. I did tell him that there is a tumor in there, and there is a tumor in the liver also. So we don't know. Usually the right atrial tumors in humans are very common, unlike in animals. In animals is a rare case scenario. So in humans, right atrial tumors are basically myxomas, which are, they normally do an open heart resection. In humans, sometimes they end up doing chemotherapy and then do an open heart resection. But in pets, those things are definitely not possible. So I told them that let's get a small CT done, and trying to confirm whether there are other tumors, and whether instead of being a myxoma, it could just be a metastatic one, because there is a tumor in the liver also. But they were like, ma'am, will come back tomorrow again. So most of the times, how it is in a field, pet parents are not very pro into diagnostics. They don't want to spend much on the diagnostics. So what we did that day, we drained out the abdominal fluid, but we couldn't drain out much because there was not much fluid in there. And I did put, I did recommend him to start him on sildenafil. I gave him some bronchodilator, that is teriflunin, and I asked them to come back in a day or two. But then I get a call in the night itself that he again had a couple of episodes of syncope, and he suddenly passed away. Right. So this is what happens in these complicated cases. They usually come down either in the extremes, or if they need further advanced diagnostics. Now, what is our conclusion in this case? I would say definitely, I don't know what kind of right atrial tumor it is, but if it were to live, I would have gone for further diagnostics, like at least go for a CT scan, trying to know if there are any other tumor apart from this. And if there is a possibility, I would have done a liver biopsy for the tumor, because I cannot get into the right heart to get a biopsy done. So I would have done a liver biopsy, or any other tumor anywhere in the abdomen. I would have done that thing to get an idea if it was a lymphoma or not. And also would have discussed with an oncologist, just in case if there could have been something that we would have been able to do to a chemotherapeutic management of the patient. But unfortunately, he didn't give us time. So this was one case. So it did look like a heart patient because it was dyspneic, but it was not a true heart patient. Okay. So this is why I call it as a cardiac mimic. Now, coming to the next case, another very beautiful patient, Milo. Milo was coming to me for more than a year. She actually came down to me saying that it was having a dry hacking cough in the night, especially. So looking at the age and being a miniature Pomeranian, when I did the echocardiography, it turned out to be that it did have mitral valve degeneration. It had backflows. So we did start it on the triple therapy. It was about a year that we was managing with it. She was absolutely asymptomatic, but after a year's time, she comes back to me saying that she was becoming dyspneic again, and it was the coughing episodes were increasing. But this time the cough was like, instead of being just dry hacking, it was like goose honking. Sometimes the cough, it used to take a little long, deeper, like that. Okay, it used to take a little longer. What do you call episode for to relieve itself. And so this is what it has come to me. And so the X-ray, that is what the X-ray looked like. In February, she looked very she was an obese, she was hypothyroidic for a miniature Pomeranian. She was pretty obese. So you can see the spine and the skin, how far they are from each other. Anyways, so it was being treated for mitral valve degeneration. It was kind of okay. If you look at this thing, very, very mild regurgitation, we were able to manage her pretty well. So these were the videos of February. You see mild mitral regurgitation, but she was absolutely fine. So this is how she was when she came in February. And then after 2 months again, she comes back like that. Mild increase in the degeneration thing, but she was still fine, though we saw that there was a slight increase in the episodes of coughing reflexes, but that's why she came back. But we redid her thing. We did her chest X-rays. We did the ECGs and everything. She looked pretty good. So this was the what do you call X-ray from the April. Her chest looked the way it used to look, slightly increased in the size of the heart maybe, but it looked fine with the lungs. We shot up her bronchodilators a little. We still continued her triple therapy, and we said, okay, examine for 2 to 3 weeks. If she doesn't pacify, please come down to us. Okay, so they're supposed to give me an update every week on phone. Now, but what happened is, within a month's time, it comes back to me saying that, ma'am, the coughing episodes have further increased, and it is not able to sleep. It is feeling very distressed. If you look at the X-ray down here, this is the X-ray from May. And what you can see here, there is a compression of carina. Here the carina is visible and round. But here you see the carina is compressing because there is something sitting over the carina and it looks pretty big, which I was not able to visualize in April. But in May, it was more and more evident and more clear. Okay. So we did take multiple X-rays from all different views. So this is one of the good X-rays that I had. So that's the reason I put it over here. Now, I did counsel the pet parents. What are my probable differentials? One is definitely a primary lung tumor. That was my primary thing, because looking at her age, the complications, there is a possibility of the lung tumor. So primary lung tumor is something that thing. And, maybe a parasitic, having an esophageal thing, a nodule, that is another thing. And, or anything like, the descending aorta affections, they could be multiple things, okay? After I counseled them, I told them that, why don't we just go for, I explained them the risk, that it is a very high risk if I do an FNAC, because it is right next to aorta. It's not going to be easy. It's going to be tough. But if you agree, then I will just go ahead and do an FNAC of whatever the lump I'm visualizing. Okay. Or else another option is to get a CT scan done and see, and then seek an oncologist opinion. But unfortunately, the owner denied the diagnostics. He said, I don't want to do anything further, ma'am. It's an old dog and I don't want to take up anything further. So if you want to do any treatment or take it up without doing further diagnostics, I'm willing to take a chance. I said, okay. So then what I said, I asked them to send the stool sample, and I said, let's examine the stools. So this is how my patient looked like in April, if you see the abdominal breathing. Okay. Had good mentation, but an abdominal breathing here. So this is how she was, and she was really bad. It was difficult for her to even breathing. You see that inspiratory dyspnea. It's trying to hold herself for a much longer time, had reduced mentation. So Milo was, once we did the fecal examination, we did find the eggs of Spirocerca. So she was advised and she was suggested for the Spirocerca treatment. But, only after 2 shots of doromectin, we lost her, though we did not see a great decrease in the size of the nodule over there. So whether it is truly a Spirocerca nodule, or it is some complicated growth, or if it is both, I have no idea, because further diagnostics were denied, and unfortunately, we even lost. Okay, and we lost her for breathlessness, basically. Now, coming to the case 3 here. So this girl, Brownie, she's coming from a family who rescues dogs. And so they ideally didn't have much idea about her age, but she was a grown-up, kind of a grown-up and adult when she was adopted by this family. And so they have multiple dogs. So they have another 2 dogs whom I have been handling for the cardiac issues. But this girl never came in for any of those. So what the explanation, description the owner gave me was, she was slowly getting breathless for almost a year's time. So they thought that it is an aging process, so she's slowing down. But her breathlessness episodes were started worsening. And because she already has 2 cardiac patients in the house, she understands what cyanosis is. And she, if you see the tongue, even now, she looked slightly cyanotic. And what was more concerning was, this girl was not lying down to sleep, and she preferred standing and putting her head over the chair and sleep. So this was something very weird, and owner felt that this is something that she would need an immediate attention. So after a few days of this kind of behavior, then the owner got it for examination. So it has a very classical, pretty nice grade murmur. You can expect a murmur in a 13-year-old pet. So this is how she came in. She was okay. She was alert. She just wanted to sit with her wide stance. Okay. Now, we did chest x-rays. As we took up the cardiac, I said, okay, let's first do the chest x-ray and see. What do you see here? So what are the chest x-ray talk about? Where is heart? I'm not able to visualize the heart. It means the cardiac heart is not visible. Caudal lung lobe, accessory lung lobe's fine. It looks kind of clear and clean. But then here I do see there is a lot of effusions. You see the lobar sign also. And then there is a very classic appearance of, what are these 2? What are these 2? These are the bronchi. Okay, the 2 bronchi, and they're usually supposed to run wide right next to each other, but then they're so wide spread out in the form of a very nice curvature. Okay, that was something very, very unusual. We did take a couple of other x-rays also, which are orthogonal x-rays, both right and left lateral, DV and VD views, not VD, but DV view. Okay, so when I looked at her, so this is an echocardiography of her, though I'm not showing you all the images out here. What you see is, this is called as a short axis view. And what you see at the center here, like a cloverleaf model, this is nothing but the cross-section of the aorta with the inverted Mercedes-Benz sign, cross-section of aorta. At the base of aorta, there is a very huge bulk mass-like thing. This is an absolutely unseen thing in echocardiography. You're not supposed to see. This is not normal. This tissue thing is not normal. Okay, and there is some pericardial effusions also over here. So this is a very classic appearance of what we call as heart-based tumors, nothing but the hemangiosarcomas. So once a hemangiosarcoma is diagnosed, there is not much you can do about it, especially, unfortunately, in India. But yes, we can start the chemotherapy. So we did start it on doxorubicin. We did take an online consultation with the oncologist, Dr. Nupur ma'am. We did take her. We drained out the pleural effusions, started on doxorubicin. As usual, the CT and all was denied, but still I started doing the chemotherapy thing, drained out the fluids, and put her on a mild diuretics. tried to give her sent the fluid for analysis to make sure that there is no secondary bacterial infections and all. And we did her an abdominal ultrasound, but I did not see any other tumor like its spleen or anything. I did not see the tumor. So basically, we thought that it is a primary heart-based tumor or hemangiosarcoma. And if you see here, the right lateral X-ray, you don't see anything, but on the left side, you see this, a very classic appearance of, this is what is a very classic appearance. That kink, the kink of the trachea, this is not normal. The trachea is supposed to come down like that. It feels like as if something is pushing from the bottom like that. So the entire heart is not pushing up. It's only just before the division there is this curvature, and that should give you the sign that this is something which is not normal. Okay. So this heart-based tumor, all the different beautiful views of heart-based tumor. Now the ECG looks absolutely normal. So she was started on furosemide, a bronchodilator, doxorubicin. We did do analysis of the fluid. It didn't show any. It did not show atrophy. It means inside the thorax we did not see any other tumor or anything. There was no secondary bacterial infection also. So was purely tried to treat for the heart-based tumor itself. Now, but it's brownie started deteriorating very fast, started progressing very fast. But you see that the paradoxical breathing after a couple of weeks. Again, the chest started filling in. Again, we drained out the fluid. It looked like chyle. Okay, and the tumor, you see the pericardial effusions also. There is a small, we don't know if it is actually a growth in the right atrium also, the typical hemangiosarcoma. But we couldn't put her on the later recumbency a lot, so I don't have a lot of views of this echocardiography. And she started slowly progressing really, really bad. We did multiple drains. All these x-rays are before and after drain. We did multiple drains on her in a couple of weeks itself, and then again lost her. Okay. So most of these cases are extreme cases. They come down to you only in the last minutes, but at least they teach you so much. So this lecture is basically trying to focus and trying to show you things, what could be your differentials. Not every breathless dog is a cardiac patient, okay? Now let's look at another case. A very simple, not simple, I would say, a very short referral case. So these people were referred to me from a very far off place, and it's a rescued indeed. They rescued this dog during the COVID time. So they were so this girl was with them. Looked like an old dog. She was with them only for, I think in less than 5 or 7 months. They said that it's a spayed female because her ear was chopped. And so she had started, they started noticing that there was a distension of abdomen. She was getting breathless. She was always panting like that. She was not comfortable sleeping even in her sides. So, and had very occasional episodes of cough in past 2 weeks, which started slowly worsening. Very, very classic signs of either a respiratory infection, but because being an old dog, very classic signs of the heart involvement, isn't it? I would have just gone and done an echocardiography and is like, wow, this is a heart patient. Triple therapy pe chalu kar do. If I don't have an echocardiography, pimobendum pe chalu kar do. Isn't it? That's like very, very classic appearance. But honestly, let us do the chest X-ray. The first thing you do is a chest X-ray. Fine. Oh, wow. Where is the heart? I don't see heart. It is all opaque. And look at the trachea. Trachea is literally touching the spine. It's a very classic tracheal elevation, compression of carina. Because the trachea is elevated, the carina is compressed, and you see those bronchi, it's all like, diverging out, literally compressed. Now, because of that, you see an open mouth breathing, and this is nothing but aerophagia. Oh, wow, this looked like terrible, terrible X-ray, isn't it? So what do? The first thing that you should do when you see a patient like that is put it on oxygen. Okay, that is your life-saving thing. Put it on oxygen. Now, once you put it on oxygen, once the patient stabilizes, please try not to write on the screen. So once you put it on oxygen, the patient stabilized, and then we go ahead and we try to tap the chest as to drain the chest out. So I usually, before draining, if possible, I just do a simple standing T-fast just to make sure that it is fluid that I'm draining and where the heart is, but like this, because like this, you cannot see. So I like doing a quick T-fast if possible, or else you can, whenever you're draining the thorax, when you're doing the thoracocentesis, try, especially in patients like that, who are old patients, try to go as caudally as possible, anywhere after 8th intercostal space, and put the patient in sternal recumbency or make them stand and do just close to the costochondral junction in the anterior border. That is what I like doing it. So we do a literally surgical prep. We try to shave the trim. We take a big area on the chest and I always approach from the right side. So I do a nice big prep, clean it up, give a local anesthetic at the intercostal junction where I'm planning to poke, put a marker, for the initial thing, you can put a marker. I use my thumb as the guide. I go my thumb, poke my, and for my thoracocentesis, I use mostly, the intravenous catheters, the cannulas, based on the size of the dog, anywhere right from the 16 or 18 gauge, I go up to 26. Depends upon the size of the patient and how good it is able to tolerate. And usually try to take a big bore one because the catheter, the plastic catheter, is little sturdier enough. And you might have to end up using multiple of them, but always use a three-way stop clock for this. Don't let the air gush in inside. Okay? And always collect the first few drops, collect the fluid whenever you're doing a chest. I think it gives you loads and loads of information, okay? We did the chest tap, we drained out the fluid almost, can you imagine just like an 8 to 10 kg dog, and we drained out almost 1.8 liters of fluid from the thorax. It's a huge amount, trust me on that. Now, after draining, I should have seen a very, very clear chest, isn't it? But even after draining, I could hardly see, she's a little bit better on the breathing aspect, but not much. And I don't see, she's still panting, she's still distressed. I see still there's a tracheal elevation, maybe a slight caudal displacement of the trachea, but I do see some lung lobe now, a clarity of lung lobe, caudal lung lobe, little more better. Maybe a little bit of cardiac silhouette I'm able to see, but most of it is still very opaque. Okay. Now, when she was better, when she was a little bit better, we put them on diuretics and asked them to come back after 3 or 4 days, just to make sure, usually ask them to come back after 48 hours to make sure that the fluid doesn't refill again. I just learned it out of experience that usually does happen that way. When I did on the day one, when I did the T-fast, I saw the shape of the heart does not look good to me. There is something that is sitting over the heart, which is not normal, but I still put her on diuretic just to make her feel better and ask them to go back and come back after 2 days. They come back after 4 days, but they're staying far off. They'll come back after 4 days. What you see here, see my heart looks crushed, literally. See, these should all be lungs, right? You should not be able to visualize any of this. Heart should look very clear and big. But there is something sitting over the lung, which is completely compressing the heart like that. Okay, and that's a mediastinal space. And as usual, it looked like a pretty nice, good mediastinal growth, or it may be either mediastinal or a primary lung. We have no idea. But usually, when there are things like that, they're in the mediastinal space itself. And I recommended a further diagnostics for her because I like depending on the CT a lot, but they denied. They even denied for blood work. They said, ma'am, it's a rescue thing. Whatever, as long as she's with us, we're okay. You may not be able to give a lot of life. And they opted for euthanasia. And it was euthanized after a couple of weeks, actually. So my diagnosis for this was tentatively a mediastinal mass. But truly, we do not know yet. Okay, so that did look like a cardiac case, and that did look like, dyspnea, respiratory affection, paradoxical breathing, fluid in the lungs, everything looked like a pretty advanced stage of heart disease. But my heart was okay for a 12-year-old. I did not see a lot of mitral regurgitation or not, because there was a huge compression from the top. There could be some turbulence, but it was not a true mitral regurgitation. I mean, not to the extent the valves weren't so bad that it could actually lead to pleural effusions. Okay, so it was a case of cardiac mimic. Let's look at another case. Ah, beautiful. So this dog was referred to me from one of a government setup, and wonderful vet. I have huge regard for this man. Though he is in a government setup, he does so much of his study, and he keeps discussing a lot of cases with me. So he did refer to me this patient, and so the complaint was, sorry. So this is how the dog does. What you see here down here is all rice and curd. It is the vomit. So he says that this dog, this very classic, this kind of thing. Okay. So it is suspected for, it has been non-responsive for the treatment for lung affections. And occasionally he keeps vomiting. It has been treated by, it's coming from Mahbub Nagar, that is like all the way from like almost 200 kilometers from my place. They have already done the treatment over there multiple times, few months. And then they came down to Hyderabad. And Hyderabad, the vet who has referred to me, he's like, no, why don't you just go ahead and rule out the cardiac involvement, because it looks like a dry hacking cough. So when he came down to me, the first thing we do is, after taking the history, we do the chest X-ray, and the X-ray did not look normal to me, not with respect to the heart, but other things. I told him, I tried to counsel him that, see, looking at the history, looking at the chest X-ray, to me doesn't truly look like a heart patient. So don't waste your money on doing a cardiac evaluation and all. But the guy was very, he was too honest to his primary vet. He is like, no, ma'am, sir ने बोला है, I must look into the heart. I will look into the heart. आप बस heart करके मुझे भेजिए, बाकी का कोई test नहीं चाहिए मुझे. I said, okay, I did it. Sent him that it's a non-cardiac involvement. The patient's heart is absolutely fine. But when you look at the chest X-ray, do you see anything? And anyone want to talk about this X-ray? Please go ahead, unmute yourself, and please do so. I shall give another 10 seconds for this. Anything abnormal that you look in the chest X-ray, please. Okay, I saw something.
Tracheal stenosis.
Trachea is not straight.
Pardon me, ma'am? Yes?
Trachea, it is not parallel, ma'am. Like it is not parallel to the ribs, nor like the vertebra.
Okay, yeah, that is something normal. Trachea is not supposed to be parallel to the spine. In heart patient, it goes up like that. We call tracheal displacement.
Ma'am, there's megaesophagus.
Absolutely. Whoever it is, can you please tell your name me?
Mahima.
Mahima, wonderful. So here it is. That was a plain X-ray. You see a very classic borders of esophagus, which is not supposed to be seen in a regular X-ray. So what happened is, after counseling him, I sent him across. He did not listen to me. He went with a supplement of heart, nothing beyond I could give. And then he comes back to me. He gives me a call directly after about a month's time. He's like, ma'am, koi response nahi hai. Whatever the other test you were saying, I'm willing to do. Let me come down. I said, you're welcome to come down. All we gave is thoda sa contrast pilaya, and then you have a very classic appearance of megaesophagus. See that? So whenever I see things like that, and looking at the age, megaesophagus in a 5-year-old, absolutely not normal, isn't it? The symptoms started appearing like, on and off vomits and all. And he started showing as if something is stuck in the throat. Started showing only for a few months or so. So I'm like, this does not look to me, which is coming from birth. Okay. So I started looking into the thing, started taking the history back. So what I said was, I asked him, what is the staple food? So it's like, well, most of the times he likes eating curd rice. That is what people say. He likes eating, though they give only curd rice. And most of his meals are only rice, and a bony dog, and always eating rice. Okay, so there are certain. I did my, before this, I did my lot of my study and research on what do you call hypothyroidism. So megaesophagus, there's a secondary megaesophagus can happen because of hypothyroidism, and there are publications, especially in humans, saying that people who are more dependent upon the carbohydrate diet are prone to hypothyroidism. I extrapolated to a veterinary science, especially in pugs, that was absolutely true. And I have loads and loads of data now, and my own research of last 6 to 7 years of my data. So So I counseled him saying that, look, this is what I feel it is. And I would like to go ahead and check his thyroid. Now, we recommended him how to do a Bailey's chair and gave him all the pictures, images, and everything. Nothing worked with this dog. A 5-year-old does not want, and that to a Labrador retriever, he does not want to sit into the Bailey's chair. So the owner found a way to feed him like that. So he used to start feeding him each and every grain like that. And he's been doing for a few months, he did like that. Okay? Wonderful pet parent. Anyways, so he turned out to be severely hypothyroidic. And this is the year is after 2 months. You see the body score condition. The dog has actually put on weight, and he also has overcome all his skin affections, which he has been going through very, very chronically, right? So, okay. Now his condition looked pretty nice. His symptoms are specified. Why have I put this slide is, so this publication came through from one of our professors, Dr. Satish Kumar sir, and then that, talking about how megaesophagus, we treat for the hypothyroidism, how the secondary megaesophagus can reverse. So yeah, that is a beautiful review that guy has given. I feel very happy, so I put that on. So this patient was actually going through a secondary megaesophagus. It took it took us almost a little more than a year to see a complete reverse of this. What I mean to say is most of the pouches have gone. So the esophagus is visible like a little picker tube, but he is completely over his symptoms. So this was a secondary megaesophagus, hypothyroidism-induced secondary megaesophagus, which was reversible by God's grace. And now he is absolutely fine. And I think he's almost 9-year-old now. And I believe that no news is a good news. I haven't heard him for more than a year now. So probably he's all good. Okay. So that thing, as if something is stuck in the throat and trying to throw things out, is also one of the classic signs of cardiac patients. And here we do see those signs, but it is not a heart patient. Okay. Another very beautiful case. This is more like a little complicated one. So I was being referred some of very complicated cases for second opinion. These are all CRPF dogs. They used to come all the way from Chhattisgarh, drive down or maybe come in a train, stay back here, and just for the diagnostics. So this patient was Belgian Malinois. And when it comes to these bomb detection or the narcotics detection dogs, they usually end up having loads and loads of tumors by the time they're 8 or 9-year-olds. But this dog is a very young guy, about just a 3-year-old. So when I took the history from his handler, what he said was, ma'am, since the dog has been given to me, she is always on, he's always on the leaner side, but give him a little bit of exercise and he gets tired so easily. Sometimes he's open mouth and he's just panting, he's all blue, he doesn't want to work much. So I always have to end up giving him his workout only in small bits. So if you understand, basically government spends a big load of money on maintaining these guys, purchasing and maintaining these guys. So discarding these guys at the young age from their duty is kind of an extreme possibility. They have to have a very, very big reason for that. Okay, so he was, one of the vets who was working with them at that point of time, Dr. Sumed Sastry, he referred, said, why don't you just go and rule out the cardiac issue and come down? Because being a 3-year-old, there is every possibility that it could be going to congenital defect. And it is also on a lower tone on the body score. Okay. So look at the heart, kind of okay, maybe small little patches here and there, but kind of cardiac, oh my, it looked okay. So now Boris, when I did his ECG, that looked absolutely weird. It is a very classic left bundle branch block. And look at the chest X-ray. Look at the echocardiography, how it looks like. The people who are actually doing echocardiography, they will understand this is a very classic appearance where let me show you. if you see the valves, the heart valves are almost attached to the tip of the thing. Okay, but still the pumping capacity was good. The left side of the heart was kind of okay. So it was almost like it is a case of what we call as almost an Ebstein anomaly, wherein the tip of the valves are almost attached to the apex of the heart. Okay, so this is a congenital heart defect, and does that convey you that it is whatever the dyspnea it is going through is because of the Ebstein anomaly? Normally, patients end up having, they come up with the right heart failure with a lot of ascitic fluid and all, but this dog did not show anything to me like that. But yes, with the left bundle branch block, there is definitely a possibility of exercise intolerance. And because the left side of the heart doesn't show a lot of good pumping, so there is every possibility that it can become cyanotic, it can be exercise intolerant or not. Okay, fine. We diagnosed the case. We were very happy. Oh, wow, this is something I found a new congenital heart defect in my, another feather in my cap. And I was very, very happy about it. And I've sent him across saying that there's nothing much I can do about it. Right? What can I do about it? It's an, if it is in humans, there are some options. But for the pets, there's nothing much I can do about it. I told him that it is going to be that way. So when you have to give a report to the CRPF guys, you have to give a very, very detailed explanation, a very detailed report. They authenticated, they put it in the record, and also I was very careful in mentioning there is no medical management that can be done about it, neither surgical for now for animals. A cauterization or anything cannot be done in these. So it is going to be the way it is. Okay. And then with the precaution that it should not be given a very heavy exercise or jumping up, jumping heights and things like it should be denied. And if possible, if they could retire more on the medical background, it would be great. But then what happens? If you need to retire the dog on the medical backgrounds also, they have to have a very, very strong reasoning. And because in India, cardiology is not still very developed and not has a lot of awareness. So my report was not given a lot of weightage with respect to retiring the patient. Okay, so now what happens? After about a couple of months, I get a message from the handler saying that, ma'am, my dog has not laid down and sleep. He's standing and sleeping for almost 2 weeks now and is very dyspneic. So I said, okay, take permission and come down because they have to take all these things, right? So they did come down, and if you see the chest, what does it look like? Chest was entirely filled, right? A lot of opacities now because you see here some apical lung lobe here, some black. So it definitely looks like loads of fluids in there. So we drained out the fluid and then asked them to come back. That fluid was sent for the analysis, and it turned out to be loads and loads of infection. Now we did multiple drains. They kept coming, and it took almost 4 weeks for us to completely clear off the chest. And then Boris started lying down and sleeping, and that's how the video was sent to me by the handler, and he was really happy. Ke ma'am, finally Boris late ke soya hai. Okay, so this was a pyothorax. So is pyothorax related to my cardiac? No, right? So pyothorax can happen because of any injury. And these are guys who go on a patrolling in jungles for kilometers together, right? So this dog was from Chhattisgarh, and they have a lot of jungles there. So we don't know if it got injured somewhere, some thorn, some poke somewhere, which has led to an infection, and it slowly grew, and eventually it has come down that way. Okay. So I'm trying to just explain you that whatever this dyspnea that, or whatever the complaint that Boris has not lied down and slept in two weeks was not because of the heart. It was not because of Ebstein anomaly. It was not because of the left bundle branch block, but because of the infection inside the chest. Okay, it was because of the pyothorax. Right? Okay. Now, coming to the next case. Are we doing good, doctor? Are you guys able to hear me?
Absolutely, ma'am.
Okay. Am I boring?
Yeah. No, not at all.
Just kidding.
Very interesting cases,
So,
ma'am.
yeah. Well, this lecture is my treasure, doctor. Almost close to 6 to 7 years of my learning, and most of these cases are under publication. So I try not to share loads of data because then I won't be able to publish them. Okay, so this is I think it is 2025. Yeah, it was in the mid 2025 I got this case. So Jinno comes to me like that, and he's always like that. You understand what I'm saying? He's always like short breaths, chota breaths, and he has partially cyanotic mucous membrane, and he always is like that. He's like doesn't like to work out much. He has been that way since he was a puppy. Has mucous membranes not very, and he's kind of a leaner on the side. And always initially they thought that they got him used to hand feeding, so they felt that usko haath se khana pasand hai. But then the primary vet, the one who was referred to me, then he said, why don't you put the bowl on the table and see if he likes to eat? And he loved eating at an elevation. Okay, so these were the only thing that he was told to me, and he was referred to me. There was not much of the signs or symptoms, but on the exercise intolerance was only the most common thing. And being a pup, I was again interested. ठीक है, 3 साल का है, he's young guy, so I probably might be looking at something interesting, because to me, congenital heart defects are something which are very rare. So, and I like to have almost everything in my bucket. So I'm always eager when it comes to young dogs and if they're dysnic. Okay. So that is what the history has come for. Okay. Now we took the chest x-rays. What do you see here? The right lateral, that's huge. The left lateral, again, a huge heart, right? And when we looked at the ECG shows a low voltage QRS, but then the rhythm was absolutely normal. Okay. Now, what you see here are, if this is the cardiac cell heart, these all black patches or this defined shaped patches is not something which is normal. Okay. So I call up primary vet and I said, I don't really think I'm looking at the major heart issue here, but I'm looking at something much more interesting than that. And so I'm going to counsel them for something else. Is it okay for me to take up further? So you have to actually, have the opinion of and the consent of the primary vet too in a referral practice. So he was also very eager. Ma'am, I will tell them, even if they're denying it, please take it. Let's take it ahead. And if you're seeing something interesting, and we don't mind putting money ourselves to learn. Okay, that sounds good. I went ahead and fed him some contrast. What do you see here? Anyone, please.
Intestines are herniated.
Fantastic. Into?
Thorax.
Thorax? So when you say thorax, you should see the intestine everywhere else also, right?
Peritoneal, pericardial, diaphragmatic hernia.
Fantastic. Who is that?
Dr. Snehal.
Oh. Wonderful. Yes, doctor. Absolutely. So I love looking at this image down here. You see the cursor where I'm putting in? So there you see here, there is a connection here, right? That little contrast here. So probably that's where the diaphragm has started herniating. Yes. If it is, yes, there is definitely intestines in this area, but it is not spread out into the thorax. The intestines are very defined and they're shaped and they are over the heart itself. So they are inside the pericardium. Okay. So this is a peritoneal pericardial diaphragmatic hernia. We did explain them everything. We said that this definitely needs a surgical repair. And, I even have took up an opinion of my mentor, Dr. Padan sir, to operate on him. But the owner did not turn up yet. And I'm hoping someday he'll come back for us because the dog is still doing fine. What the treatment can be given? Nothing. We just asked him to definitely avoid feeding any bones or anything, loads of solid foods, trying to put him more on the semi-solid and kind of a liquidy diet, more on the liquidy diet. Except for that, nothing much could have been done for this dog. Okay, but it's a fantastic case of surgical repair, but I don't know, they didn't come back. Another very beautiful recent case that I've come across, and I have learned loads from this patient in multiple ways, and I definitely would like to share. I'm still learning, I'm still interpreting this case, but still I would like to share this one with you guys. So this is a case of just last month. Happy, about 7.5-year-old female, intact female Spitz. She comes down to me in a very, very grave situation like that. So they literally came down, lifting her in their arms, and it was not referred by any vet, but rather it was, they researched it through the friends. Friend has referred to a vet, the vet has referred to me. So things like that. It has been just, loads of chain of people before they came down to me. So they wanted to understand. The first thing that the owner told me was, ma'am, will it survive? This was the thing he asked me. I said, before I could answer that thing. It's a very, very big question. Let me try and understand what has happened. So he says the patient has been recumbent for more than 48 hours now, almost like 4 days now. And it has been breathless, and it has been like that, absolutely not eating or drinking anything. And it has been only put on IVs. Initially, the patient was being treated for renal failure and for more than 10 days now, and at other hospitals. And because they did see the renal values. So the renal values kept increasing, but even after the treatment, it was not going down. Okay, so it was more like a non-responsive case. So they came down when I saw the patient, if you see here, it was, look at the breathing, right? Very difficult abdominal and paradoxical breathing, partially cyanotic mucous membranes. It was hypothermic. Okay. So we took the chest X-ray, loads of fluid inside the chest, and also the fluid was there in the abdomen. So what you see down here is the video saying that, yes, that is the fluid inside the abdomen and the fluid inside the chest. I'm sorry, I put it the reverse. So this is the fluid inside the chest, and this is the fluid in the abdomen. We did quickly. I like putting my probe on because of the machine. I like putting my probe on. I like collecting my data. I just got used to doing those things so much. So before taking up, but before doing any of these things, the moment a patient comes like that, the first thing you should do is put it on the oxygen. Whatever you do further has to be done while the patient is on the oxygen. Okay. And what we did, first thing we did was, that is how the kid came down to us. We drained almost 900 ml of fluid. We drained out the abdominal fluid, started feeling better. So that you see here, distended abdomen. Abdomen has gone down. She felt much better. Look at the eyes here. Look at the eyes here. Open mouth, comparatively started breathing a little bit better. So dyspnea was slightly improved. She was more comfortable lying down, okay? Now we know that there is fluid inside the chest. So after oxygenating again, hoped some more time, then we went ahead and then we drained out the fluid from the chest. That was pseudosanguinary fluid, almost red fluid. Approximately 100 to 120 ml of fluid was drained from the chest. And it was done in 2 episodes. We actually gave her a break before we drained out further. And it was only done from the right side. And you see that she's much better now, breathing much better than before when she arrived. Now the abdominal movements have also kind of calmed down, and she's sleeping. Okay, that's how she was. But if you see, the dyspnea is not completely gone, isn't it? Even after removal of fluid from the chest, the dyspnea was not gone completely. Now, if you look at her, she's actually lying down on my echo table. I would never miss a chance of echoing her. What is that? Dr. Mahima, Snehal? What's that? That's loads of pericardial fluid, right? So your heart is dangling. That's the entire, that's a pericardial effusions. That is pericardium here. and your heart is dangling in there. But this is the right atrial collapse. So you all understand the right atrial collapse is because of the increased pressures. The right atrium starts collapsing, and when you have loads of pericardium. So the pericardium is so stiff and distended that, you know, even if you touch it, looks like it's going to rupture. Anyways, I took a chance. I'm sorry, I didn't post the video here, but I took a chance. I went ahead and drained out the pericardium. It was an extremely risky case. If you try and understand, it was a 7 or 8 kg dog, a small dog like that. You will have a heart of approximately this size, a pericardium completely attached close to it. And then the fluid inside the pericardium fills in. So the overall, the heart size would not be beyond this, I believe, or maybe this much. So in that space, towards the apex, go ahead and poke it, a blind poke, very careful. So we tried to do that, and we drained out approximately 25 to 30 ml of fluid from that little heart. Sorry, I didn't post the video post after the pericardiocentesis, but if anyone is interested, please message me. I'll be more than happy to share. So this video tells about the fluid that we drained from the pericardium is not blood. It means we did not touch the heart. It is actually the fluid. So even after 30 minutes, it's not going to coagulate. Okay. So that's how she looked like. That is how she was when she came to us. That is how she was after abdominocentesis. That is how she was after thoracocentesis. You see all those 3 years? What a drastic change. And that is how she was after pericardiocentesis. Isn't that lovely to see like that? Yes, it took quite a few hours for us, but then we did everything one step at a time. We first drained out the abdomen, then we went ahead and drained out the chest in a couple of episodes. Then once the patient was stable, once it started breathing and doing pretty well, then we took a chance at draining the heart. Okay, so for me, this was an extremely challenging case, and probably the only one so far. I have handled approximately today was my 1742nd patient, 1742 patient that I have done so far. I've done the cardiac evaluations, out of which this is the only patient that has come to me with the fluid in all the 3 chambers. So far, I have handled 2, but I've never handled all the 3. So this was, thanks to my staff, wonderful people with the great patients. And yeah, it was an absolutely wonderful learning for us. And then we took the blood, do the basic blood work again, because we knew that she was in renal failure. We did the blood work, counseled the pet parents, and then, asked them to come back the next day again to make sure that the fluid doesn't start filling it back again, to make sure that the heart is kind of okay, because the pericardium was so badly distended. I was so scared that one single needle poke would also rupture it. But God's grace, things went well. So she was absolutely fine like that, was not even allowing us to touch much. So that is a pet parent who is doing all that. And this was after 1 week. Okay. Now, when I looked into her heart looked really good. I did not see lots of any of the mitral regurges. Her mitral valve looks fantastic. Her tricuspid looked fantastic. Then what had led to so much of fluid everywhere? It was actually her renal failure, because we understand that in renal failure, because of, once the RAS activation, initially the RAS activation happens to compensate the failure, but then eventually the overactivation can lead to all these things. Fluid retention, especially what in our general terms, what we call renal failure will lead to fluid retention. And so my conclusion to this case has been that patient was in renal failure. It took about, we did the regular renal failure management. Trust me, we have not put her on loads of fluids, rather of IV fluids that when I say fluids, my apologies. I say we have not put her on a lot of IV therapy, but we did put her on kind of 50% to 80% on sub-Q fluids. And though normally on an average 70 to 100 ml per kg body weight is what is recommended for giving the IV therapy, of which maybe 50 to 60% should be NS and the remaining should be RL. But there were a lot of compromises we have done on this aspect. to make sure that, but she was put on Pronephra, she was put on, we have given her oral binders like Kinetra. She was put on also on those, Renodis or Renodil capsules, which are responsible to chelate the ammonia from the gut. She was put on that. She's completely on renal diet. It has been 2 weeks now that we saw her, but she is doing great. We have asked them to repeat. They keep repeating. Initially, we kept doing the kidney function test every 2 days, and then we have been doing we did one or two times with the gap of 5 days also, and the most recent one also was her renal values have come down to less than 1 now. So she's great. She's doing very good with the renal functioning. So what I realized is correcting the renal thing. I did put her on after her 1 week evaluation, I did put her on pimobendan a little bit. We saw mild regurgitation, but it has been put on only 0.25 mg per kg body weight, and it's only for once a day, just to make sure the pumping capacity is really good, just to understand that probably she's not going through any insufficiencies, or to kind of delay down the secondary cardiac remodeling, which can be a sequelae of the renal failure. Okay, which would it is not just the renal failure sequelae. It is basically it fastens the secondary cardiac remodeling. To slow that thing down, she is being put on pimobendan, and she was put on diuretics, but she's not on diuretics anymore. Right now she's only on renal diet. She is on she's not on Pronephra either, but she is on those Renodis capsule to chelate the excess of ammonia. That's it. No diuretics, nothing. So this has been a wonderful, wonderful case of learning. I'm still learning from this. I'll repeat her echocardiography after about a month's time to understand, because in the recent echo, in recent TPAST, I did not see any pleural effusions. There were no pericardial effusions. There was no ascites. Her renal values have improved. So she has shown a drastic improvement. And okay, by the way, we have sent her all the 3 fluids for the analysis. None of them have turned out to be with any of tumor cells or any cellular atypia. We have not seen anything like that. So yeah, still I would like to, at this point of time, I would just like to say there's probably a renal failure complication that has led to this, but definitely to me, it is not a cardiac patient. At least not that aggressive cardiac patient. It could lead to the fluid accumulation in all the 3 chambers so acutely. Okay. So finally, I'm presenting a feline case, and then I'll close the lecture. So this is an old case, 4 or 5 years old, and to me, the patient was referred like that. It has been treated multiple times. It's a 3-year-old and non-immunized male cat, and has been treated for respiratory affections multiple times, and then slowly it has been having this breathing difficulty, non-responsive, so it was referred to me by the primary vet. Look at the weight, it's just 2 kgs, 3-year-old, a long, tall Persian. That was his chest X-ray. So Romeo showed everything like opaque chest. So the primary suspicion should be, oh, is that a fluid? I put my probe on. I did see some fluid in there. I said, okay, let me drain out the fluid first to ease the comfort. So now the caudal lung lobe is much, much wider and bigger. So the breathing should have been much, much better. Okay. So this is what is brachysynthesis in cats. Instead of using a cannula, mostly I try to depend on a butterfly. So if you see the transparent fluid, it was not jelly-like, but it was transparent. And the fluid was sent for analysis. The blood work was also done, turned out to be negative for FIP, but we did it. And we even did that, the saline test to see if it was a high protein one, but it was very transparent. It was very thin fluid. Now, this was before thoracosynthesis, and this was after thoracosynthesis, but I do see there's still a lot of opacities left out. I don't see the cardiac silhouette, the shape of the cardiac silhouette very clear, okay? So went ahead and did an echo after a couple of days. What is that? Okay. So my heart is smushed out at a corner, and there is a load of big blob of things sitting over the heart. Remember, we have seen thing like that earlier too, right? With Blackie, the stray dog, so there was a lot of huge, big blob-like things sitting over the heart. So that huge, big thing was the entire thing was looked like a growth. When I even put it on the Doppler, there was quite good blood supply. Now this dog, this cat, I did not want to leave him. After my experience with the other patients, I said, okay, let me take a chance. I told them that they don't have to pay one single paise, either for the treatment or for any of the diagnostics. Their only commitment is they have to come down whenever I call them. So the owner was a young guy. He was doing his graduation, Danish, wonderful kid. He said, okay, ma'am, just let me know one day ahead so that I can come back from my college. I said, okay, done, fine. So we planned his CT scan in a human lab, and we did it in the midnight, honestly. So we took our entire team so that we could give her a mild sedation and do the CT scan. So this is how the CT is. So this entire white thing, what you see, is a tissue, some kind of growth. That is the heart. Okay, this little thing is the heart. Now these are the lungs. So the entire space in the chest, this is the stomach. So that entire space in the chest was occupied by a huge growth. So that entire thing is a growth. These are the trachea and bronchi. This entire thing is the growth. Okay, a mass. That's the heart. These are the lungs, okay? So that time, fortunately, we had Dr. Jayaraja sir visiting Hyderabad. So, we invited him to a clinic, and God's grace, he came down on the same day. We called this patient also. And I wanted to do an ultrasound guided FNAC for this kid. So he himself helped me. He himself collected the sample. So we did this, and it turned out to be a very classic lymphoma. And after it turned out to be lymphoma, once it was confirmed through FNAC that it was a lymphoma, then we went ahead and we started the chemotherapy, which was a Kotakop protocol of chemotherapy, where vincristine was used at 0.75 microgram per kg per meter square, and it was given as an IV therapy. So this was the day one of the chemotherapy. See, paradoxical breathing, abdominal breathing, open mouth. This was the second chemotherapy, which was done after a week. The breathing looked much, much better. It was great. And then this was on day 22nd. See how alert it is? From day one, if you see here, it's more pink and it's more alert, and the breathing has improved drastically. So only we literally stopped. So every single time we did this, on the day of the chemotherapy, cyclophosphamide was recommended only on the day of chemotherapy. And then we did put it on everyday prednisolone once a day, which was continued for, though we kept track of its renal values and everything. But yes, the prednisolone was continued for almost about, I think, 20-25 days, and then we slowly tapered down and stopped it. Now this video, after that, once the patient became this good, then, you know them, right? They never come back. So it took a few months for me, and then I literally had to coordinate with them because I wanted to show this case in a lecture. So literally I had to bug him up to send me this video. So that's how Romeo was in October. After a few months, it was like that. Absolutely fantastic. And I shall share you how the X-ray looked like. So this is how he was in February with that kind of chest and the growth. And this is how he was in October after he completely recovered. Okay. So if you know, lymphomas are very common in non-immunized cats. And this is something which is I have read, and actually when I after the case itself, during that process, I started reading, and that's how I realized how common they are. I was guided by Dr. Jayaraja sir for the treatment part and for the FNAC of this patient, but I'm extremely thankful for that. So this was a very successful story, though everything was done at an expense of a clinic, but it was worth learning. It was worth learning. Okay. So that was a mediastinal lymphoma. It means though you see paradoxical breathing, though you see respiratory affections, distress, the patient, it may be a very classic appearance of, even in the HCM cases, which end up having pleural effusions, the patient looks like that. But this turned out not to be a cardiac patient. Okay. So what's my learning? I'm trying to emphasize here that this overall thing is there could be a lot of differentials. So start looking, taking a history is very important, not only at the instance when the patient comes down. Also, sometimes you might have to do a recounseling, or maybe you have to just sit down and discuss, try to jot down every single thing. When you have such complicated cases, try to look into this could be something I don't want to miss. And learning from your differentials is way, way, way more productive than actually just jumping into a single conclusion. Okay, so there could be loads of things that may look like a heart patient. Like I have seen severe pyometra cases showing huge arrhythmias. I have seen splenic masses. Because of splenic mass, you see, varied ECGs. And they also come dizzying. They also show exercise intolerance. Okay, now I have shown you one renal failure case. GDVs, we all know how GDVs are. Brachycephalic airway syndromes, yes, because of the complete compression of the almost collapse of the trachea due to the redundant tracheal membrane, almost not even 10% is open. They end up being extremely dyspneic, and if the dyspnea is maintained for a long, hypoxia is maintained for a long duration, you know that it will lead to, heart will either pump strongly or pump more number of times. Either ways, it works more than twice, and that's how you end up having hypertrophy. Okay, hypertrophic cardiomyopathies are very, very common in PAS, in patients showing the brachycephalic airway syndromes. These are all irreversible changes, right? And I have showed you multiple tumors, which are within the heart, or it may be in the thorax. Okay, laryngeal paralysis also sounds, it looks like as if the patient is going through respiratory affections, maybe because of the heart. Okay. So mostly what I want to just conclude is keep your eyes and ears open. Try to take a very, very detailed history, not only during the first visit, but also the consecutive ones. And there is no shortcut to success. There is no shortcut to learning. So, I always refer this, what you call a quick 5 minutes consult, the Blackwell 5 minutes veterinary consult, especially for differential diagnosis. I quickly go through them. I jot them down for such patients, do my own study, do my own research before I, go ahead. But yes, the most difficult thing in a practice like mine is more than 50% of the times patient don't give me time to handle. So anyways, I'm done with my presentation today. There are loads of people I'm extremely thankful about. So all that is a big list of people who have been referring to me. There is still, this list still need to be updated because this is almost a year-old list. And for specifically, trying to study heart, we started Veterinary Cardiovascular Society, and we started it as a small group of people, interested in studying heart. We call them as VetCardians, and eventually we formed this Cardiovascular Society. We've done a wonderful, huge Congress. After doing this Congress, we realized that we were the first one in the world to do a heart-specific conference. We never knew that, but after the conference was ended, then we realized it. And through Veterinary Cardiovascular Society, we have already done 2 hands-on trainings. A lot of people, I think, in our audience also who have attended that. And there's another one which is coming up very soon too. So this group, basically, the society, we also have a WhatsApp group. We study cardiac cases. I present cases. A lot of other people who present cases, or sometimes we even just put up a little small question, and then we have studying. It's a self-study group. You definitely have to do everything by yourself, but we are there to guide you through, and also for the mutual learning. Okay, so we're welcome. I would say, you're welcome to join us. If there is anything that you can that's my number. You can put a question to me directly. I'll be happy to have you on board. Apart from that, if you have anything, any case, any ECG or anything that you would like to discuss with me, you're welcome to share me on WhatsApp. This is my only number, and I'll be happy to assist you, but I will not be giving you a direct solution. People who have been studying along with me for so many years, they know me, but I'll definitely help you learn and look into whether it could be a cardiac thing or not that you're looking for, okay? We can study together. Thank you so much for Drools for all the 3 sessions. You know, every single time you present, you learn so much. So I got to learn so much, and I'm very happy for this opportunity. And especially, it's a great honor to have an Indian origin company trying to help us learn so much, trying to promote the education. And we wish you good luck for taking this thing up. And I really hope that you do it in all the other disciplines also.
Yeah.
Thank you so much
Thank
for
you.
the opportunity.
Thanks a lot, ma'am. I would say the pleasure is all ours to have you on board, to have you on board and take time out of your busy schedule and educate all us veterinarians with all the treasure trove of knowledge what you have. So we are deeply and sincerely thankful for you and your time. Thank you, ma'am. And now we would like to open the floor for the questions. So anybody who has a question, either they can use the chat box or they can raise hands so that one by one we can address all the questions. We can raise the hands, or if we are able to put it in the chat box,
Read
we'll
out the
address
questions in the chat box.
so that ma'am can also read out the questions in the chat box.
You want me to read out myself? Okay, I don't see any questions here.
No, as of now, there are no questions.
Okay. Either I was very boring, or I was not interesting, or everyone understood everything. So
Please pour in the questions. We have enough time.
yeah, I mean, the wonderful thing is there were 100 people by the time we finished our thing. It's great, actually. It's a great audience. I'm happy. For a weekend, it's a great audience.
True. So if nobody has a question, they can always reach out. Dr. Satyanarayan Sahu, sir, please unmute yourself and ask the question.
Yes, I will. I shall share. I mean, you can just message me on my WhatsApp. I'll be more than happy to have you on board in Veterinary Cardiovascular Society. Okay, people are asking me about, so I'll just put in a message, my phone number again, 9.
Hello, good evening, ma'am.
Good evening.
The webinar was excellent.
Thank you, sir.
But the thing is that many veterinary doctors who are posted in India in district headquarters hospitals are not aware of the cardiac problems.
Yes,
Then they don't have amenities for all the diagnostics. Maximum they can do is X-ray.
Yes, sir.
So
that much is enough.
It
Trust
will be
me,
better
that much is
if
enough.
the X-ray will be sent to you by WhatsApp and it will be diagnosed by them. That will be an immense help. And if some other technocrats who will help them in diagnosing by receiving X-ray, it will be of immense help to the veterinarians of India. Thank you.
Yes, I will help you understand your chest X-rays. Chest X-rays alone cannot be diagnostic enough. I can help you understand what you're seeing in your chest X-ray. Then you can draw the conclusions from that. Okay, you cannot expect me that you post a chest X-ray and ask me to give the treatment. I will not be doing that. I never do that in any scenario. But yes, I will help you understand, read the chest X-ray, what are the details in it, so that you and I can help and conclude and try to explain the situation to the pet parents and what further can be done. That I will be more than happy to do it. Okay?
We have a couple of questions in the chat box. I'll read out to you, ma'am, one by one.
Yes,
the first question from Dr. G. Subhash Chandra Bose. Megaesophagus, if we came, we go for surgery or oral medication is sufficient, ma'am?
So you cannot incise an esophagus even in humans. Only medical management. We have used some prokinetics, and it had worked really, really well in my case. But mostly, more than any other thing, dietary management, trying to put the pet at an elevation for feeding so that it doesn't, get accumulated in the chest. That's the primary thing. Putting on prokinetics so that the process goes on much easier. Apart from that, trying to identify the reason, because it was a 5-year-old and the signs and symptoms started a few months ago. So my suspicion was it's definitely not congenital. If it is not congenital, is there something that is causing this thing, and can I rectify it? And one of the very major primary causes for megaesophagus, secondary megaesophagus, is hypothyroidism. So we went ahead, looked for the thyroid. It turned out to be hypothyroidic, severely hypothyroidic, to be honest. And then I ended up treating for hypothyroidism, and it responded pretty well. Yes. In humans, there is a surgery for a secondary megaesophagus happening because of eclasia cardia. It means constriction at the spot where the esophagus is entering into the stomach. It's very tight and constricted. In that case, there is a beautiful endoscopic procedure which is called as a POEM, per oral endoscopic myotomy, where they put they go through the mouth, till the end of the eclasia cardia like that, and they try to cut. They create incisions. So they just try to widen the cardia. They try to widen the opening. That way, now the food flows off much more easier. So the accumulation in the thorax or in the esophagus goes down, and the symptoms are pacified. Okay, but in animals, I really don't know if anyone has done a POEM yet. But identification of eclasia cardia itself takes not only the contrast X-rays, but the CT also. And at least I have not done it in this case. And because this was a very direct, etiology, and we rectified it, and God's grace, it responded. If it wouldn't have responded to that, I might have even recommended going for a CT or not. I'm a crazy person. I don't mind spending myself if the patient are not willing. I spend myself because I need to learn. So that if I learn from one patient, rest of the 100, it will be much more easier to diagnose. So yes, in our patients, definitely try to identify the root cause. Go for the medical management. Not only the medical management, most important is the management of the patient in terms of what to feed, how much to feed, and those things should be done. Okay. That's how it has been.
So the other question from Dr. The other question from Dr. Murthy is site of needle insertion from abinocentosis, thoracocentosis, and pericardiocentosis.
Please understand, when you say abdominocentosis, it's in the abdomen. I try to take it slightly caudal, touching to the navel. That's where I do it. Very easy, safe. There's nothing much to poke in, and there is loads of accumulation there. When you come to thoracocentosis, suspected cardiac patient, heart, you should feel that could be enlarged. Your heart is supposed to be anywhere between 3 to 5 intercostal spaces. Avoid it. Go as caudally as possible, 9, 10, 11 intercostal spaces. It's very safe. And try not to poke in this direction towards the heart. Try to poke it towards the abdomen if you're scared. You're understanding? The orientation of the needle should be slightly towards caudally. So at least you're not touching anything that way. And try to do it in the lower 1/3. Don't go on the upper 1/3 of the thorax. I try to go as sternally as possible. It's safer. Pericardiocentosis. Pericardium means in and around the heart. Very risky. But you have to go. All the major blood vessels, everything is towards the base of the heart. It's towards the 3rd intercostal space. You have to poke in between 4, 5, 6 intercostals, right? It has to be ultrasound guided 100%. But you cannot take a risk of touching the base of the heart or any of the part of the heart. It can lead to instant arrhythmias. So when we are doing pericardiocentosis, we make sure that the patient is put on the vital monitors to make sure that the ECG is running, and definitely has to be on the oxygen. And I especially like going ultrasound guided, and I go by 6th intercostal space, and try to go as sternally, like almost perpendicular, so that the cult, it means the pericardium, which is the bulged end, is towards down. So you're just touching the cult enough so that you're just entering the pericardium and start draining it out. So we normally don't even try to draw things out of the pericardium. What I do is I poke it and I just take out the snub, and it starts falling down. I don't use a needle or anything. I just allow the flow to come down, because I'm so scared that any little pressures and the tip of my needle or my catheter touches the heart, and instead of saving the life of my patient, I might even put it at risk. So pericardiocentesis, especially in the small dogs, is a very, very careful and a risky procedure. But in the bigger dogs, you don't have to worry that much because there's loads of fluid and it's very easy to poke, and you can even use a 3 ml syringe or a 5 ml syringe drift out. That you can do. But in the small dogs, be careful. Don't use a plunger. Nothing. Kuch nahi laga ke chhod dene ka, it will drain it. And try to avoid as much as possible. Try to avoid a butterfly needle or anything. Try to use a catheter. Yes.
The next question what we have is, ma'am, can we prescribe pimobendan without doing ECG, X-ray, ultrasonography?
Arey yaar, ye kya baat hui? Definitely no. A big no. You should never recommend a pimobendan based on just an ECG or based on just an X-ray. Definitely not. Pimobendan, you must start it only after echocardiography. I do understand there are loads of constraints. Guys, please understand. Pimobendan is not a life-saving drug. I am managing so many heart patients even without pimobendan. I'm sorry I didn't say it loud. Company wale meri jaan kha jayenge. So pimobendan is a fantastic drug. Try and understand the concept of using pimobendan. What this does. It is a positive ionotrope. It means that it improves the contractility. It is not responsible for contractility. It improves the contractility. Next important thing. It helps in increasing the contractility of the heart without using extra oxygen. So it is not taxing the heart. Third very important thing. Pimobendan helps in slowing down the secondary cardiac remodeling. Okay. So it can be used as a supplement so that it can be slowly allowing the patient not to rush into a lot of degenerative changes. Okay. So now, if you ask me, ma'am, without doing any of this thing, kyun chalu karoge pimobendan? You must understand it is your trump card. You just cannot waste it. Right? And pimobendan need not be started on a patient if there are multiple stages of the disease. It's a degenerative, slowly progressive heart disease. You need not do it. You need not do it. Be very, very judicious in using this thing because this could be a life-saving thing. Start using it when it is mandate, when it is needed for sure, only then you start using it. For example, in a DCM case, you might have to use it. Right? Because there you have diastolic failure. There is a defect in the relaxation. So your contractility will go down. The pumping capacity will drastically go down. Usme you might have to have used a pimobendan. How can an ECG tell you that how you have to use a pimobendan? No, that is an absolutely a big no-no. Okay, it's something very crucial. Start using it very judiciously. Yes, please.
Yeah. The other question what we have is, few cases coming with ascites due to cardiac reason, please treatment suggestion.
Please understand, when you say ascites, you have to rule out if it is cardiogenic ascites or not. If you say it is a cardiogenic ascites, then you have to have a very strong basis to say that. It means you should have a clear-cut diagnosis by then. You have to have an echocardiography. Bina echocardiography ke, you cannot say if it is a cardiogenic ascites. Ascites heart patient mein kab hota hai? When the left heart has already failed and then the right heart failure is happening in a very advanced stage of the heart disease, or in a DCM case, or in a congenital heart defect. Only then you will see a right heart failure. Only then the ascites will happen. Okay. So if it is a heart patient, you know there are 3 reasons for that. Treat the reason. DCM, you know that you have to use some diuretics, use some pimobendan, and use ACE inhibitors in the starting and to control it. Try to improve the pumping capacity of the heart. Okay. If it is a congenital heart defect, there's nothing that you can do about it. Drain the fluid out as much as you can, even to the last drop. Counsel the pet parent that it is going to fill again. But I might give something like sildenafil to probably reduce down the pulmonary hypertension. So there could be a chance of delayed progression. You can use in the non-responsive cases of, it means like I have one case which is non-responsive to any of the diuretics. So I started using thiazide on it and it responded pretty well. Now, instead of a patient refilling the fluid every 1 week, 10 days, now the patient comes back to me in 2 or 3 months. And I'm happy about it. It's okay. It's a 14-year-old Dacian and coming back to me once in 4 months for draining or once in 2 months for draining. I'm okay with it. It's like that. Okay. So please, when you say it is a cardiac origin ascites, please delineate the reason. It is not common. It is not common. So how to rule it out? We don't have access to the cardiac thing. Don't worry. First thing you do is put it on the oxygen, drain out the fluid. Extra compartmental fluid है, कितना भी निकालो कोई फर्क नहीं पड़ता. I drained out 13 liters of fluid using a 25 ml syringe for almost 4.5. I have pictures also of that. 4.5 hours on a Labrador. Literally 13 liters मैंने पूरा bucket भर पानी निकाला है मैंने. कुछ नहीं होता. It will not ever lead to dehydration. Trust me. It's an extra fluid which is of no use. You don't have to put an IV fluid again. Don't do that. You don't have to replenish it. It's not a circulatory volume. It's an excess of extra fluid. Don't do it. And don't you ever think that just putting it on the Lasix is not going to allow the fluid to refill again. That is a wrong concept. You have to understand the reason why the ascites is happening. So ascites, if it is, to rule it out, पहले drain कर दो, उसके बाद में look at the liver. Do the fluid analysis to make sure that there is no other tumor or anything inside, which could be the reason for the effusion. Okay, rule that thing out. If it is not hepatogenic, if it is not because of the tumors, then go ahead and look into the heart. Do the chest X-ray, देखो कि कैसा दिखता है, and definitely an echocardiography. Only then you can conclude that it is a right heart failure. If you manage the heart, the fluid accumulation will go down. ठीक है?
Second question what we have is, please share more about Ebstein anomaly, ma'am.
Ebstein anomaly is a congenital heart defect because of it's a type of a tricuspid valve dysplasia. It means that, see, every valve, the leaflets are attached to the papillary muscles to very thin thread-like structures, which are called as a chorda tendineae, right? So in those things, in an Ebstein anomaly, the chorda tendineae are very short, and instead of getting attached to the papillary muscles, the chorda tendineae are attached to the apex of the heart, the tip of the heart. Okay, so the valve, instead of closing like that, it is 24/7 open like that. It doesn't close. And it is all displaced down there. The valve leaflets look as if they're touching the apex of the heart. So because it is not closing, the right side of the heart is always loaded, and that is when you end up having the ascites.
What is the treatment of Megaesophagus?
Megaesophagus, as I said, we have to put them on prokinetics and then try to find the reason for it.
Okay. So next question what we have is, how to deal with the cases of Diarofilaria immitus, and what are the typical signs?
Heartworm. Heartworm is a very big subject, typically not seen in India. That is what it is said. God's grace, I have not come across one yet. But you should see, in the chest X-ray, you should see a pretty good wide aorta. In echocardiography, it is said that you'll see them as a very clear-cut lines. Because I have not come across any of those, I don't have any idea about it. And, you can even look at the warm eggs in the stools. So I have not come across, so I am not the right person to talk about it. But people who are from the Northeast, I think, and even in Kerala, some of the cases have been reported of the heartworm. And there is a very, very clear-cut a protocol of what kind of antiparasiticides and for how long it has to be used and for how often you have to repeat it. There's a very standard protocol by WASAWA guidelines, a very standard protocol for heartworm thing. If you want it, maybe you can message me. I'll try to find out the paper and I can share it with you. But fortunately, I've not come up yet. So I'm happy about it. But it's very difficult. Yeah.
Okay. The next question is, how to differentiate between renal or heart-related pulmonary edema or pericardial effusion?
Very, very good question. It's a very direct approach. The first thing is KFT is something that we'll talk about it right away. But if it is renal affections, now if you ask me whether the heart was first affected or the kidneys, तो मेरे पास अंडा मुर्गी वाला सवाल का जवाब नहीं है, right? Because it is at an age 7.5, 8-year-old. So either the heart could have gone bad, which might have led to low cardiac output, which might have led to low renal perfusion, and which might have led to the kidney failure. or my patient might have gone into an acute renal failure, maybe because of multiple reasons, like some kind of poisoning ho gaya, ya fir, drug insult ho gaya, because it's not eating or drinking or something like that. People put it on loads of prednisolone, people put on doxycycline, jo bhi de deta hai, and they very easily push the patient into a renal failure within no time. 24-48 hours are enough for the kidneys to go bad. Any kind of AKI, acute kidney injury, can also lead to this thing. And in those cases, you will definitely see, because of the decreased perfusion, then you'll start seeing the fluid accumulation. It's like literally a cycle, right? So if you ask me, these effusions, why are they happening? I would say it's a very straightforward approach. 99% of the time, they happen because of the heart. It's very, very common. The case that I've shown you is a very exceptional case. Why? Because it has come to me in a kidney injury, but I slightly tried to improve the cardiac functioning. I first of all evacuated everything. So now the load on the kidney is very less. Now the load on the heart is also very less. My performance of my heart will increase naturally. So the cardiac output has gone up really well. Renal perfusion has increased because of that. Whatever the little creatinine was present in the blood, I tried to flush out. Okay, so it has worked in the multiple ways. It means you're washing the kidneys, you're increasing the pumping capacity, you're improving the renal functioning by just improving the functioning of the heart, by reducing down the load on every compartment. मैंने volume overload reduce किया, मैंने pressure overload reduce किया, मैंने extra load from the outside मैंने reduce किया. That itself had led to an increase in the functioning of the heart. आउटपुट, कार्डियक आउटपुट बढ़ जाता है तो रीनल परफ्यूजन बढ़ जाता है. रीनल परफ्यूजन बढ़ जाएगा तो डेफिनेटली सब कुछ फिल्ट्रेशन वगैरह भी नॉर्मल होने लगेगा. दिस इज हाउ इट इज. Okay, so but if it is a patient is already in the renal failure, suspect the pleural effusion can be because of the renal, but don't avoid doing an echocardiography, because echocardiography में अगर तुमको बहुत ज्यादा recursions दिखते हैं, then you're in a big loop. It could be a cardiorenal syndrome also. Okay.
The next question is related to cardiorenal syndrome. Ma'am, have you come across any cardiorenal syndromes? If so, in short, explain the management of the case. So in continuation, what you said just now.
Yes, I do have patients going into cardiorenal syndrome, especially chronic DCM patients, which we have been managing for 3 to 4 years. And long-standing, they continue giving the same prescription, even though the patient has gone into an asymptomatic occult stage of DCM, but still, they keep giving diuretics, they keep insulting the kidney, and usme chala jata hai. I have definitely seen those things coming up. So my main thing is always remember, there is a golden rule when it comes to kidneys. If the kidneys are compromised, heart ko bhul jao, pehla kidney handle karo. That's the mother-in-law of the house. You have to manage it. There's no exception. If the kidneys are good, the rest of the things can be managed, because whatever little thing you're going to do to the rest of the body, it is going to tax the kidneys further. So if a patient is coming to a cardiorenal syndrome, I would first protect the kidneys, do the flushing, 24-48 hours, repeat my kidney values to make sure that it's responding. The renal values are coming down. If my renal values are coming down, then I start looking at the blood-urea nitrogen, how often it is coming down, how fast it is coming down, or is still there an accumulation or not. If it is not there, then I go ahead and do my cardiac evaluation, and then I start thinking of improving the pumping capacity of the heart. Okay, that is what you should do. Always, always save the kidneys, please. That is a mandate. That has to be the golden rule. That has to be the thumb rule. Okay, so in our clinic, we have a very clear-cut system from day one. I have maintained it like, once I'm done with my patient evaluation and everything, there is a bottom line where I write down follow-up. So based on the stage of the patient, based on how good the patient has been managed or whatever, the follow-ups are either in 3 months or 6 months or 1 year or whatever, they must come down. So we try to have a system of giving the reminders also. In about just 1 week ahead, we give a reminder message that to come down. Apart from that, if it's a geriatric patient, if I'm asking them to come back after 6 months, I ask them to keep repeating the kidney function test at home, in-house, किसी भी clinic में जाके वो कर सकते हैं, and keep sending me the kidney function test in the WhatsApp every single month. So I keep track of only the blood urea nitrogen. That has to be constant. मेरे को creatinine से कोई मतलब नहीं है. My blood urea nitrogen should not fluctuate in my old patients. If it is fluctuating, the first thing I ask is कितना बजे ब्लड निकाला था पहले और अभी कब निकाला है, 2-4 दिन पहले क्या फूड दिया था, कितना पानी पी रहा है. These are my questions. If all these parameters are normal, then I tell them, okay, 4-5 दिन अच्छे से पानी पिलाओ, cut down on the meat, do these things, repeat the kidney function, send it to me. Now, if I still see my blood urea nitrogen is not fluctuating, then I ask them, now calm down. I need to check the heart. ठीक है, इसीलिए बोला था शुरू में, heart doesn't work by itself and heart doesn't work for itself. Okay, fantastic questions, guys. They're asking slowly, but I'm enjoying it. Wonderful.
Yeah. As far as you are enjoying, ma'am, we have a lot of questions to ask. So the next question we have from an intern, Dr. Akshita Purohit. She has asked, I wanted to ask about the renal failure cases. Have you also gone for IV human albumin administration because there was fluid accumulation? Because she has seen the trend. No,
I don't do any albumin. I don't do any. Hypoalbuminemia in humans is, replenishment is common in dialysis cases or in cases where they are doing a continuous draining. To me, I don't need it. My patient live for a small period of time, and if I'm not able to manage in first 48 hours, then I know I'm handling something more critical. मेरे लिए first 48 hours are very critical. If after 48 hours I'm seeing my creats are coming down, my bun is fluctuating, I need not add it. That is good enough amount of protein. Why do I add protein? Why do I tax the kidneys more? No. The breakdown product of protein itself is your this thing, right? Creats, right? So मैं क्यों tax करूँ? Dialysis patient में दिया जाता है because they're doing so much of flushing. In animal patients, do we do the dialysis and do we do the thing? I am not doing dialysis, so I am not the right person to answer.
The next question what we have, ma'am, is why does hypothyroidism lead to megaesophagus?
Yeah, read it out. Read it out. Fantastic question you have asked, whoever Dr. Vet is. I have already shared an image of the paper. Please read it out. It's a very, very... so what does hypothyroidism do? It leads to change in the metabolism. It leads to all the muscle weakness, right? All the muscles become more and more flabbier. That's one of the hints. Go ahead and read it.
So next is related to the megaesophagus only. Madam, sildenafil suggested for treatment for megaesophagus.
No, I have not used sildenafil. There are a couple of papers. Whoever is asking me this thing, they have definitely done their research. Yes, but I have not used it, sir. Yes, there have been a suggestion of using sildenafil in megaesophagus cases, but I have not used it. I have only used prokinetics and did this. It turned out to be pretty great if it is not congenital. If it is congenital, there's nothing I can do about it.
The next question what we have is, ma'am, if a pleural effusion in cats comes and we want to rule out is it because of a cardiac origin, then we should do the echo before tap or after tap. And is presence of fluid changes the value of mode. So for final diagnosis, when we should do the echo.
Remember, forget about any diagnosis. If you see fluid in the chest, oxygenate, drain it. That should be your target. You know what? I normally don't do all my complete detailed echocardiography. If I see pleural effusions or pericardial, the same day I don't do it. I ask them to come back after 48 hours so that now the hemodynamics are more stable. Now my values are much better. You should allow the heart to work in a lesser load. ठीक है, तब जाके उसके proper parameters of measurements आप ले पाओगे. Same day I never do it. Always remember, saving the life of the patient is way more important than all the numbers. If you see fluid, it is completely just like, when you go home, just do this, hold your breath and see for how long can you hold. And I want you to feel the moment you release it, that very second. You do that, right? And I truly want you to feel that. Because that is how your patient is going to feel once you drain it. That ha is what your patient is going to feel. So if you see the fluid in the chest, don't do anything. Put it on oxygen, drain it. Put it on oxygen, drain it. Khatam. Next, when you do a detailed echocardiography, when you have fluid in the chest, you can never have proper parameters because you have so much of hemodynamic derangement. So please don't do it. Allow the patient to stabilize pretty well. And then go ahead and do an echocardiography. all this fluid, the pleural effusion is outside the heart. It is definitely not going to change your M-mode measurements. If you see pericardial effusions, you're definitely not supposed to, if you're definitely not supposed to take any measurements, you first have to drain out the fluid either through the medical management or through the poking or whatever. Medical management also it can be done, but sometimes it takes months to drain out. I have a wonderful case like that. It took me 3 months to completely drain out the fluid, improve the pumping capacity, drain out the fluid in a dog. But it would have been very easier for me to just poke it and do it, but the owner didn't allow me. So yes, if you have pericardial effusions, you're not supposed to echo, not supposed to take any measurements. If you have pleural effusions, please drain out, save the life of the patient, allow the hemodynamics to work for 24-48 hours pretty well, and then go ahead and do the measurements. Then you'll see a lot of, you'll see something which is close to the normalcy of that patient. Okay, you'll get much more accurate data that way. Okay.
Should pericardiocentesis done under USG guidance?
Definitely yes. There is no question about it. Definitely yes. कहीं पे भी पोक मत कर देना. मैडम ने बोला है सुई डालने को, सुई डाला तो गया patient. Please don't do that. Okay. How to read X-rays, any sources. I am just a vet student, but you're a fantastic vet student because you're asking great questions. You can DM me. There is a wonderful, very simple book I can post. Okay, start reading it. I'll be more than happy to guide you through. Okay, whoever Dr. Vet is, if you're listening to me, send me a small message. I will share you the book.
Under what circumstances you may sedate a pet for any interventional diagnostic procedures, and what sedatives you generally prefer?
I never do it, irrespective of what, because if it is a cardiac, it's already compromised. Cardiac patient kabhi bhi agitated nahi hota hai. If it is an agitated patient, it means that I'm not looking at heart, I'm handling something else. Or if my patient is excessively panting and stressed out and not allowing me to do, not lying on the side or so, I mostly oxygenate it. They calm down with that. Usse bhi nahi ho raha hai, to butorphanol at the dosage of, half of the recommended dosage. That's it. But I never had to use butorphanol in last 7 years of my career of cardiology. मैंने कभी भी नहीं दिया. Have some patience. Use the oxygen as much as you can. They will stabilize. Trust me. I find handling pet parents is way more difficult than handling the patient. They're so cool. My patient is so cool. I can handle them very well. And God's grace, my staff is so wonderful that, now they're trained. So they know how to handle behavior of the patient. We understand. Sometimes we even allow the patient to stay in the reception for much longer time or just give them separate room to calm down. When sabse nahi hota hai, to you can just go ahead and start using butorphanol, 0.1 mg per kg body weight, but you do not need it, and that too only sub-Q or intramuscular. You don't need it IV. I've never done it.
The fluid therapy in pets suffering with kidney disease and cardiopathy, rate and volume of choice. Can you elaborate more on fluid therapy?
Fluid therapy, am I supposed to talk? But theek hai. See, what was I trying to emphasize? Please understand if the renal compromise is because of the heart or not. If it is because of the heart, improve the pumping capacity of the heart. Then whatever little fluid you're giving, for example, I already mentioned ideal renal failure mein 70 to 100 ml per 70 to 100 ml per kg body weight in 24 hours is the dosing. Okay, for which mostly 50 to 60% has to be NS and about 40% has to be RL. Right? This is how it is. Normal convention. Now, if the patient is into a renal failure because of the compromised heart, if that is what your deduction is, try to improve the functioning of the heart also, improve the pumping capacity of the heart. At that time, my doses are much lesser. I use approximately 40 to 50 ml of NS, 40 to 50 ml per kg body weight of the fluid therapy. Among that also, only 50% I give through IV because I don't want to tax my heart, and 50% I give a subcut. So that way I'm taxing the heart less, but still I'm maintaining the fluid, still the perfusion is happening, still the filtration is happening, and still the kidneys are being flushed, slightly slower rate. Okay? But if it is not because of the heart, then you can just manage a regular. If the heart is not compromised, it looks fantastic, then just go ahead and treat the regular kidney failure patient. If it is an old dog, first 2 to 3 days, rigorous IV therapy, see the renal values are coming down or not. Once they're coming down, and if they stabilize, like, ma'am, 1.8, 1.9 ke niche ja hi nahi raha, don't worry, that could be normal to that patient. But encourage and train the pet parents. I have some DCM patients जिसका renal value slightly high होता है, तो I even train them for doing a sub-Q fluid at home. सुबह एक बॉटल दोपहर में लगा देके छोड़ देने का, वो इतना बल्ज बनेगा, दूसरे दिन शांत हो जाएगा. So it will be like that. I ask them to do it a few days and then recheck the renal values. I tell them that, yes. Okay.
Now we have the last question. Nowadays, cats suffer mostly from renal failures and initially urethral blockages and severe cystitis, sometimes bleeding in the urine. How to avoid it?
Am I supposed to answer that, doctor? When you say increase renal values, please understand, try to first take into account, especially in a cat, try to first take the account as stress. Stress is something which will also cause sterile cystitis in cats, and any kind of burning sensation in the urine. The cats try to withhold the urine for a longer time, and it itself can lead to kidney failures. And you can understand that increase in the creatinine among the cats, it just happens like that in few hours also. Okay, so the answering that question is it's very, very difficult because there are multiple reasons for that. Second important thing is they are mostly on the meat-based diet. So you really have to standardize and understand what are the normal values for that cat of that age. Okay, another thing, they are very thirst drinkers. Even in the stress, they don't drink. So, when a patient comes to me in the renal failure in the cat, I even ask the pet parents to go home and click a video of their entire house where the cat lives, where the dog, cat food bowl is, water bowl is, pani kaise pita, pure ghar ka main video mangwate. It's important because just with the medical management, you cannot do. Feline medicine and feline practice is so different from the canine ones. You don't have control over many things. And all those things is your patient is getting affected with. So stress is something that you must understand. So that is something I would always be careful about. And yes, definitely getting the renal values down. Blockages are different scenarios. We need not worry about it right now. But if it is because of UTIs, if it is not, and please make sure that you do ABST. And whenever, even if to start an antibiotic, start a very low grade amoxicillin, start with amoxicillin. Please don't rush into high grade antibiotics. Please don't do that because it could be sterile cystitis and you're further damaging the kidneys. Try to do mostly with the, counsel the pet parents how to do syringe feeding the water and all. Use some alkalizers, urinary alkalizers. Start using some potassium binders or maybe chelators, ammonia chelators. Okay, start using loads of renal diet. Encourage them to start giving the renal diet. So these things can help, a feline patient to manage the creats. Okay.
Yeah, so now I think we have answered all the questions and you have patiently answered all the questions, ma'am. So we have बहुत मजा आया. So literally everybody has enjoyed.
Thank you.
Thank you, ma'am. So we have officially come to end of our 3-part series with you. And everybody has enjoyed a lot. We have learned a lot from you, from your experience, and we'll keep having all these sessions in the future as well, so that we as a veterinary community can gain much from your experience, from your clinical experiences. And from Drools, I would like to thank you for giving Drools a platform to host you, to be our speaker for our vision to empower the veterinary community. Because apart from being a pet food brand, we always believe in a veterinary community. Dr. Shashank being veterinarian themselves, we have a team of veterinarians. We always are a veterinary pro community. So we want the knowledge sharing platform for the veterinarians. So thank you, ma'am, for giving us an opportunity. And thank you all the doctors who have taken time out to join the session. And we would have a lot more sessions to come. Thank you, ma'am. Thanks a lot, ma'am.
And I have a very personal request. Please don't ask for the PowerPoint presentation. I'm definitely not going to share because these are my personal cases and most of them from this are under publication. So please understand, do not reproduce it at any public platform. And I completely refrain you from doing that. Please understand. Okay? Let's learn. I'm happy. I'll be happy if you want to ask me anything. You're welcome. I have given you my personal number. मुझे message करो. I'll be more than happy to talk about any case that you want me to discuss. ठीक है?
Yeah, ma'am. Thank you.
so
Thanks a
much.
lot, ma'am. And thank you,
Bye.
everyone. Thank you,
Thank
everyone.
you. Have a good day,
Thank you,
guys.
ma'am.
Thank
Yeah,
you.
same to you,
Bye-bye.
ma'am.
Thank you,
Thank you.
Drools.
Thank you, ma'am.